So let's take a look at an integrated response to a decrease in effective circulating volume. Now you'll remember that effective circulating volume is not really a true fluid compartment, but it is related to cardiac output, mean arterial blood pressure, and adequate tissue perfusion. Those tissues that are important to perfuse are brain and heart. And so anything that causes a decrease in blood flow and perfusion to those organs will trigger the system to respond the same way through the same type of cascade as we're going to depict and integrate. Okay? So any decrease in effective circulating volume, be it related to hemorrhage, diarrhea, vomiting, congestive heart failure, or any variety of other entities that cause that the body's sense of decreased perfusion will trigger this system. And there are 4 major players from the standpoint of maintaining volume and adequate perfusion in the system. Those are the sympathetic nervous system, the renin-angiotensin-aldosterone system, ADH or antidiuretic hormone, and ANP or atrial natriuretic peptide. So in the case of a decrease in ECV, we have an integrated response that results in an increase in sympathetic tone. And from the standpoint of the kidney and long-term recovery from that decrease in ECV, that sympathetic tone is going to have an impact to decrease glomerular filtration rate. It also has an impact to decrease renal plasma flow and renal blood flow. But its major impact that we're concerned about in this particular situation is a decrease in GFR. There's an increase in afferent arteriolar vasoconstriction, which results in a decrease in hydrostatic pressure within the glomerular capillary, and the result is a drop in the amount of fluid that's filtered across the glomerular filtration barrier. There's also an increased release of renin. Remember, renin is released from the juxtaglomerular cells in the kidney. That renin is released. It catalyzes angiotensinogen to angiotensin 1, and then in the presence of ACE, it's rapidly converted into angiotensin 2. Angiotensin 2 in high concentrations also has an impact on GFR and will cause GFR to fall. Angiotensin 2 in high concentrations will cause vasoconstriction of the afferent arteriole as well as the efferent arteriole. Angiotensin 2 stimulates aldosterone secretion from the adrenal, so we get an increase in aldosterone release. Angiotensin 2 also causes ADH to be released from the posterior pituitary. And a decrease in ECV by itself will also trigger an increase in ADH to be released. When we talk about the kidney and all of these hormones, the net result is that there is a decrease in renal sodium and water excretion. So by decreasing GFR, I filter less and therefore I have less to reabsorb. By increasing angiotensin 2 release and increasing aldosterone release, I will decrease the amount of sodium that's excreted in the urine. And by increasing ADH release, I'll also have an impact to reabsorb the water that's been filtered and put that back into the system. So the net result will be that for everything that decreases the ECV, I'll have an increase in sympathetic tone, an increase in renin activation, an increase in ADH, and that cascade will ultimately cause a decrease in sodium and water excretion out of the system. Another way to think of this is that all of these systems will actually increase the reabsorption of sodium in water by the kidney to put back into the system. So whichever way you'd like to look at it, either there's a decrease in excretion or an increase in reabsorption. And ANP in this situation is a little bit different. So ANP, remember, comes from the cardiac atria and typically responds and is released to an increase in pressure in the left atria. And ANP typically will counteract these hormones and try and increase the amount of sodium and water we excrete. So ANP levels will depend on the situation that we're in. For instance, hemorrhage, where pressures in the system are very low, ANP will be suppressed. And that would make sense. Left atrial pressures, right atrial pressures are low. For instance, when we have hemorrhage or gastroenteritis and losses of solute and water from the system, so I would expect ANP to be low. However, in a situation like heart failure, where we have a decreased ECV due to a lack of cardiac output, the pressures in the system are actually higher. And so for congestive heart failure, ANP levels may actually be elevated. So it depends on the situations which are causing the decreased ECV to begin with. So let's take a look at the different aspects of where these hormones and systems have an impact specifically on the nephron. I've again schematically represented the nephron, all 2.5 million nephrons in this two-dimensional form. Remember, we have the glomerulus, the proximal tubule, the thin limbs of Henle, the thick ascending limb, the distal tubule, and then the collecting duct. And so let's put in where these different regulatory systems will have an impact on sodium and water reabsorption. Starting, of course, with the glomerulus. So I mentioned before in the last video that changes in afferent and efferent tone at the level of the glomerulus will have an impact on flow. And so at the level of the glomerulus, the sympathetic nervous system and the increase in angiotensin II will have the effect of decreasing GFR. And in the case of a decrease in ECV, that's exactly what you would expect. You would expect that if I've had losses from the system, the last thing I want to be able to do is to filter it and then have to exert effort to try and reabsorb it. So the less I filter, the more I actually keep in the system. So high levels of angiotensin II and high sympathetic tone will allow GFR to fall, and I'll filter less. Next, at the level of the proximal tubule, I have enhanced sodium reabsorption, and that's under the influence of direct stimulation by the sympathetic nervous system as well as angiotensin II as well. So angiotensin II and the sympathetic system will stimulate the proximal tubule cells to reabsorb more sodium than at baseline. And remember, since the proximal tubule is isoosmotic reabsorption, if I reabsorb sodium, I will also reabsorb or enhance water reabsorption. There's not much that occurs in the thin descending and thin ascending limb of Henle from the standpoint of sympathetic tone, angiotensin II, or aldosterone. In the thick ascending limb, you'll see in some references that there's an impact of aldosterone. From my perspective, it's a small impact, a small effect, and I'd much rather have you focus on the next portion of the tubule, which is going to predominantly be the collecting duct. And at the level of the collecting duct, we have the impact of aldosterone, and with the addition of aldosterone, I have enhanced sodium reabsorption at the level of the collecting duct. That's under the influence or at the level of the principal cells. And remember, I also have ADH present, which is also going to enhance water reabsorption, also by causing the principal cells to increase their permeability to water, inserting aquaporins into that apical membrane to increase the permeability. and use the osmotic driving forces in the medullary interstitium to reabsorb more water. So ADH and aldosterone will have its greatest impact in the cortical and medullary collecting duct to enhance sodium and water reabsorption. So the net result is that I have such a decrease in sodium excretion rate that it's almost zero, and I put out a small amount of water so that my urine is concentrated and the urine osmolality is high. Now, that's the integrated response for a decrease in ECV. Again, most of the work is being done proximally in the proximal tubule, where the vast majority of solute in water is being reabsorbed. Remember that in a decreased ECV, all the normal mechanisms for maintaining euvolemia are off the table. So the system is geared up to reabsorb as much sodium and as much water as possible to try and put it back into the system to preserve the effective circulating volume and maintain that adequate perfusion to vital organs.